All right. Good afternoon and welcome to today's webinar, Navigating the Centers for Medicare and Medicaid Services CMS Emergency Preparedness Final Rule. My name is Jonathan McDowell, and I am the Operations and Policy Analyst for Nevada Primary Care Association. Nevada Primary Care Association is a nonprofit organization dedicated to improving access to high-quality, community-based, and affordable primary health care in Nevada. We provide training and technical assistance to health centers and community partners to improve access to healthcare for all, especially the underserved and underinsured populations. For more information, visit us at nvpca.org. This training is in partnership between the Nevada Primary Care Association and Community Health Care Association of New York State. I want to take a moment and thank Community Health Care Association of New York State for helping coordinate this session. Before we get started, I would like to go over the logistics and housekeeping items for the webinar today. Please type your name and organization into the chat box. It's nice to see who in the community is present in this webinar today. During the presentation, please make sure to mute your phone or computer so that we do not have feedback or background noise. Also, please be sure to not put your phone on hold as we may hear your hold music. You will have the opportunity to submit your questions to the presenter by typing your questions into the chat box. You may send in your questions at any time during the presentation. Questions will be collected and addressed during the Q&A session at the end of today's presentation. Today's session will be recorded and slides will be available to all participants. I would now like to introduce you to today's speaker. Alexander joined Chicanes in September 2015. In his position as Director, Health Center Support, Alexander's primary focus is the Emergency Management EM program. He is responsible for the development and implementation of Chicanes federal, state, city, and privately funded EM projects. In his role, he provides training, technical assistance to health centers to prepare for, mitigate effects from, and provide services to their patients and communities before, during, and after a disaster or emergency situation. Alexander is also the co-chair of the Primary Care Association Emergency Management Advisory Coalition, the PCA EMAC, and provides ongoing support to national EM initiatives. Alexander holds a master's degree in social work with a specialization in administration from Hunter College, New York, and an active clinical license, LCSW, from New York State. And with that, it is now on to Alexander. Thank you so much for being here, and we appreciate your time.
Thank you, everyone. Good morning. I know you're on the Pacific time. Let me share my screen. And if we can have a confirmation that you guys see the slides, that'd be great.
We do. We see your slides.
Perfect. So welcome. With that introduction, Jonathan, very kind words. It's my pleasure to be here today because I think the PCA EMAC is the pinnacle of what we try to do. We try to share the knowledge, and this is the prime example of how we do it. Nevada and New York are part of the group of peers, and it's my pleasure to present to you on the CMS emergency final rule and the implications for Fqhcs. Without further ado, I want to jump into the content of the presentation because there's a lot of it, as you'll see. Also, we decided to ask you to submit your questions during the presentation, and we will address them at the end of the presentation because a lot of the questions may be answered during. And I think I'd like to finish the content because there's a lot of it, as I said, and we'll have a chat following. So what do we want to do today? I want to give you an overview of the emergency management, emergency preparedness expectations and regulations for you as an Fqhc. We're going to look specifically at Medicare, CMS, Centers for Medicare, Medicaid Services, and the place of Fqhcs in that program. I want to point out a couple of pointers for you for a potential audit if it comes to that, and I'll explain when and if you'd be subject to that. We'll also roll in all the most recent updates to the CMS final rule. And I want to point out a couple of resources that I think you guys would find helpful. So with that, just a few seconds of who we are. CHGANIS, Community Healthcare Association of New York State, is the primary care association for New York federally qualified health centers. These numbers are a little outdated. We have more sites and more people served. It depends on how we count them, but we're now more than 74 federally qualified health center networks across the state, and we have a robust HCCN health center network. And emergency management fits under the health center support program, and beyond COVID and response to the pandemic, my day-to-day role is to provide training and technical assistance. So let's jump right in. I want to be mindful of time. As I said, we're going to move very quickly, but don't hesitate to submit your questions throughout. So before we look at the requirements for the emergency preparedness, emergency management for Fqhcs, I think it's important to look what's really required and what is not required. Part of what we want to start with is HRSA, the Health Services and Resources Administration, because are you required by HRSA to have emergency management programs in place? Well, the answer is yes and no, because there's the Policy Information Notice 2007-15, that is an expectation. HRSA expects you to have certain pieces in there, and I think Fqhcs are under more of a expanded eye right now with everything going on, but are you required by HRSA to have emergency preparedness? Yes and no. Also, I cannot speak to your state requirements. You may have very specific requirements from your Nevada State Department of Health. It is the case for New York, for example, and in fact, our state requirements supersede the federal requirements as more stringent. So please be aware of that as well. I doubt that your state requirements would supersede HRSA and Fqhc CMS, but please check and keep that in mind. With that, let's jump into the HRSA pieces. So for emergency preparedness, in 2007, HRSA released this document, PIN, Policy Information Notice 2007-15, called Health Center Emergency Management Program Expectations. So for a while, HRSA had a hodgepodge of all of these PINs and PALs, policy assistance letters, PALs, that was providing certain guidance until HRSA reformed the whole policy for health center manual, they called it, compliance health center manual. And in that manual, I believe it took place 2 years ago, 2019. But with that restructuring, they specifically kept the policy information notice that is on your screen in green, and that is the emergency management expectation. So the bottom line is it still remains in effect, this policy, and it's not superseded by the manual, and you guys need to be aware of that. So what is that PIN 2007-15? This is a document that specifies the expectations that HRSA has on you as a participating health center program in the 330 grant Fqhcs for your emergency management programs that are in place. This is a very robust document. I highly encourage everybody to read it, specifically because it goes into detail of what HRSA wants you to have in place. That is emergency management planning. They want you to focus on linkages and collaborations. This is working with your communities and other partners, with federal, state, local, and private partners. Communications and information sharing is described, and the maintenance of financial operational stability. Read this as continuity of operations. Mind you, this was put in place in 2007, right? So 13, almost 14 years ago, and some of the content is a little bit outdated from the point of the most recent changes. However, this document is still in effect. However, it's not a requirement. If you look at the language, it's an expectation, right? But HRSA is not going to come and review your programs against the pieces that are listed in this document. So keep that in mind. However, this document became the basis upon which CMS later built the requirements for Fqhcs, which I will mention in a few minutes. Other things to keep an eye on, there's been very many changes recently, specifically with the development of the global pandemic, and also in reference to that year, that summer, where we had 3 huge storms and hurricanes. So there's a lot of pieces that went into place since then from HRSA, but I wanted to point out a couple that I think you should be aware of. By the way, you do have access to this presentation, and the links that are in blue are clickable, so you could click on those links and get the documents that I'm referencing. So please be aware of the change in scope for adding a temporary site. That's very relevant for everything that's going on. So that is definitely something that HRSA put out. There's the telehealth pieces that were put in place specifically when pandemic started developing early in the course. So that is relevant. There's also a whole bunch of stuff that's related to emergency preparedness and FTCA coverage, Federal Tort Claims Act. So all of this creates the universe of emergency preparedness in the HRSA domain, if you will. But then again, all of this is guidance and documents, and they urge you to have this, but there are requirements like HRSA, FTCA coverage, like HIPAA, releasing patient information, but it's not necessarily the clean-cut operational requirements that HRSA is checking up on you every single time they do a site visit. Other pieces related to this, HRSA for years has had this Form 10, what they call Emergency Preparedness Report. It's a 2-page document. You have the first page on your screen, and it's basically a report, self-reported, from a health center to HRSA of what you have in place for your emergency preparedness program. Do you have a plan? Does the plan have 4 stages? Are you ready? Do you have vaccination, etc.? We still don't know what they do with this information, so it's sort of there, but nobody has been able to answer who collects this information and what they do with it. But Form 10 is part of the new access point application still. And every time you do the new access point application, you need to provide this form to HRSA. Up until recently, the service area competition application was also inclusive of Form 10, but a couple of years ago, HRSA changed that. So instead of Form 10 that you just saw, instead of this form for the service area competition, you have to provide a paragraph of a narrative. So please notice in red, there is a question in this new format on maintaining continuity of services during disasters and emergencies. So in a project narrative, any Fqhc who is submitting information to HRSA for this process, you need to provide a narrative describing what you see on your screen. Current capability and plans for maintaining continuity of services and responding to urgent primary healthcare needs during disasters and emergencies. So that is a change as of a couple of years ago. And notice how everything is filling together the expectations are in PIN 2007-15. There's Form 10, but now they're expanding for the service area competition. So you need to tell HRSA basically what your plan is and what you do with emergencies. I think we noticed more of a zoom on this area after the summer of hurricanes, and now with COVID rolling, I think it's an important area for everybody. HRSA also has expectations for you guys, Fqhcs, and for us, primary care associations. So on the screen, you see a screen grab from 2019 when hurricanes were rolling. And this is a reminder to PCAs and health centers that you have to provide your operational status to your primary care association, who is then in turn contacted by the HRSA project officers to have an idea what's happening on locations. So since then, it's an official work plan that primary care associations have with HRSA. We, PCAs, are on the hook to have this in our work plans. So this is definitely something that you may be already working with your primary care association on how you will release your operational status for delivery sites to the PCA. So please be reminded that this is an official request from HRSA and something that we must do. And also HRSA has been very, I would say, prolific in their surveying, specifically when it relates to COVID. Before COVID, there hasn't been a standard survey, I would say, on how they would want to see the operational status, etc. But since COVID came out, they did release the standard survey that all of you fill out. And that is also an example of what HRSA has in place for emergency preparedness. With that, let's shift gears a little bit. As I said before, HRSA has all of these expectations, but not too many things are required. However, HRSA recognizes that you are on the hook for emergency preparedness because you are a federally qualified health center, and they view CMS, the Centers for Medicare and Medicaid Services, as that regulatory stick. If HRSA is more of a carrot approach for emergency preparedness, CMS is viewed as a stick because CMS put out a whole bunch of requirements for emergency management, emergency preparedness for Fqhcs, and that's what we're going to look at right now. So if we look at you as a community health center, within the CMS program, there's two very relevant parts that you should be aware of. There's the 42 Code of Federal Regulations, Part 405, subsection 10, and the same article of Code of Federal Regulations 42, Part 491. So 42 CFR 405 is what you see on your screen. Again, I'm giving you the reference here, but why is it important? This subpart 10 basically defines what is an Fqhc program for the purposes of CMS, meaning for you to be recognized as an Fqhc in a Medicare program, you need to meet all of these sub-paragraphs. It describes the basic requirements. Pay attention to the third sub-paragraph, termination of agreement, second, content and terms of agreement, conditions for reinstatement after termination. This is all very interesting and relevant because this subpart 10 tells you and Fqhc what you must do in order to be a provider, a supplier in the Medicare program for CMS purposes. The more relevant one, though, although we cannot judge which one is more important, but the more relevant one, in my opinion, is 491, because this is the certification of certain health facilities. A subpart related to you is called Fqhc conditions for coverage. This one, prior to the rollout of the CMS emergency final rule, right? So the emergency final rule came out in 2016. Prior to that, you had 11 subparagraphs related to Fqhcs that you needed to meet in order, again, to be certified and in order for you to participate as a Medicare provider and be able to be reimbursed by Medicare for your Fqhc status payments. Now, if you notice, prior to the CMS emergency final rule, 2016, there were 11 subparagraphs and none of them were related to emergency management. Also, please notice 491.3 certification procedures. I'll tell you why that is important. But prior to the rule, these were the pieces that you need to have in place for you to be recognized as a Fqhc provider and be reimbursed by Medicare. Now let's move to 2016. For a while prior to 2016, Medicare was talking about the final rule related to emergency management. And finally, in September of 2016, they did release the final rule, which is called Emergency Preparedness Requirements for Medicare and Medicaid Participating Providers and Suppliers. And they pointed out the following goals of this rule, why they rolled it out. They wanted, by instating this rule, they wanted to increase patient safety during emergencies. They wanted to establish consistency across various types of providers and suppliers. And they wanted to have a more coordinated response to natural and man-made disasters. There's a whole other rationale. I don't have time to explain why else, but there's a bunch of studies that were done prior to the rule. It all pointed out to disjointed efforts by various providers, and this country needed a consistent program for medical providers. That's why CMS came up with this. So the purpose was the goals you just heard, but the purpose And the three key essential elements were safeguarding human resources, maintaining the operations of healthcare facilities. So basically, if there's a disaster, you still need to have operating healthcare facilities. And there's a lot of aspect on investments made by various sources for physical resources, computers, EHRs, facilities. So all of this, the rule is supposed to help protect all of these. Now, there are 17 provider and supplier types that were affected by this Medicare final rule. And all of them, right? Take your hospitals, nursing homes, etc. They all have various names for what they needed to do, but for hospitals, it's conditions of participation. For nursing homes, it's requirements. For rural health centers, it's conditions for coverage. For Fqhcs, it's conditions for certification. No, sorry, conditions for coverage. Basically, all of this is the same. CMS established the rules that all of these 17 provider supplier types need to follow in order to receive Medicare payments, Medicaid reimbursements in some cases, and basically remain a provider in good standing in the Medicare program. So very briefly, there's three groups that were affected by this rule that CMS put out in 2016: inpatient types, outpatient types, and hybrid types. Inpatients are the 6 types that you see on your screens: hospitals, critical access hospitals, SNFs, intermediate care facilities for people with disabilities. You guys, federally qualified health centers, are in the outpatient type subgroup. You are bundled with rural health clinics. That's because CMS sees you and rural health clinics as pretty much the same, except for the way you certify your eligibility for the program. But a couple of words about that in a second. So you are bundled with these provider supply types. And then there's the hospices, transplant centers, organ procurement organizations that cannot function without hospitals, therefore they're hybrid. So they are inpatient and outpatient at the same time. So these are the 17 provider supply types. And basically, to bring you back together to the Fqhc and how is it of importance to you, the CMS rule. So prior to the rule, CMS had these conditions for coverage for you to be an Fqhc in the Medicare program. What rule did, it introduced an additional subparagraph 491.12, which is now called emergency preparedness. Pretty much every single provider supplier type within the 17 was added this subparagraph, and now every single one of them has to meet the additional requirements for emergency preparedness, and largely they are similar. However, there are some differences between them. So before 2016, there was no emergency preparedness requirements for Fqhcs. Come CMS final rule, as of 2016, you now must meet emergency preparedness requirements. And if you don't meet those emergency preparedness requirements, you may no longer participate in a Medicare program. CMS will kick you out and think of the consequences of that. So that's the approach. HRSA has some carrots, CMS has the sticks, if I may call it that. Now, fast forward a couple of years, in 2019, CMS has released an update on the emergency preparedness final rule, which is called the Omnibus Burden Reduction Final Rule. Basically, it lumped together a few provisions, including some of the emergency management provisions that removed certain requirements for being burdensome, excessive, obsolete, etc., etc. So that final rule was published in 2019. It became effective on November 29th, and it did revise certain requirements for Fqhcs. So we are going to look at some of these. Mostly, the rule revised the frequency with which you need to do certain things. Again, I'm not going to focus too much on some other subparagraph that the omnibus rule changed. That's not really of importance. But basically, if 2016 final rule added 491.12 emergency preparedness subparagraph requirements to Fqhcs, the omnibus rule basically added changes to provision of services, to your conditions for coverage, program evaluation, and of course, the emergency preparedness. So remember that. So now, basically what you need to remember is there's a set of rules that were initially created by 2016 final rule. Now, burden reduction came 2019, made some changes, and that's what we are going to review. Before we go into the CMS preparedness requirements for Fqhcs, I need to pay attention and point your attention rather to the process of how you certify for being a participant in the Medicare program, because it does make a difference for you because of the audits. So if you look at 491.3 certification procedures, this process does not apply to Fqhcs. The reason being is when you, an Fqhc, want to participate in the Medicare program, you submit a packet of documents to Medicare saying, we want to participate. The Medicare requires you, CMS requires you to submit a bunch, including a bunch of documents, including the appointment letter from HRSA. And because everything is already in existence, you self-certify that you already meet the conditions for coverage in order for you to become a provider in the Medicare program. So again, because it's a whole bunch of complicated stuff, because you self-attest, pretty much because HRSA tells you you can, you've been appointed by HRSA as an Fqhc, you tell that to Medicare, Medicare believes and takes your word for it because of the application process that you go through, and then you self-attest for you meeting all of these requirements that we just went through. There's going to be no on-site survey for an Fqhc for an initial certification, and more importantly, for recertification audits ongoingly. Basically, what it means is that unlike every single other provider who, like hospitals, nursing homes, even rural health centers, who go through an initial audit by Medicare to make sure that you meet all of the requirements to participate in the Medicare program, and then roughly every 3 years, Medicare does a recertification audit. Fqhcs are not subject to that kind of audits. There's no initial survey. There's no ongoing survey from Medicare in order to certify that you still meet the requirements. And that is very important, because if anybody tells you, oh, please be afraid of the CMS audit because they're going to come to you very regularly, that is incorrect. You should still be aware that you can be audited at any time by Medicare for CMS emergency preparedness final rule requirements, but that audit most likely would come from a complaint filed by your patient who is a Medicare recipient. As you see, the last point here is the only necessary Fqhc survey is a complaint investigation, which occurs if there is a complaint against the health and safety provision. So basically, again, to paraphrase, the only time the auditors will show up unannounced on your door is if there is a complaint and the initial investigation has proved that that complaint has some heft, and HRSA said, well, we probably need to do something about it, then CMS will send auditors to your door and you will not know about it until somebody shows up. The bottom line is, you still need to meet all of the requirements. You still need to meet all of the points that we're going to go through in a second, but don't sit and threat and think that an auditor will show up every 3 years on your door, because that's not what happens with Fqhcs specifically. And that's the only exception, because everybody else has regular audits. We always get a question, well, how will I know who will be audited? If I have 5 locations, which locations will be audited? Well, Medicare has a certification process, and because of the way they certify you, they certify each facility separately. Because basically, if you have 5 locations in your network, Medicare views them as separately certified facilities. Therefore, because they're separately certified, each separately certified facility will have its own CMS certification number, or CCN. It used to be known as Oscar P10. Right now, it's CCN, CMS certification number, that you need to be aware of. If I were to ask you, well, what are the CCN numbers for your Fqhc network? you should know how many and who knows that, because that's the number of facilities that are potentially to be audited by CMS. So CMS reviews the rosters and they know how many separately certified facilities are in your network. And again, there's a formula for how CCN looks, et cetera, et cetera. So please do some research if you're not aware how many CCNs you have for your Fqhc network. With that, there's a couple of other considerations. There is a way of Medicare to certify the permanent versus non-permanent. So basically, Medicare approved Fqhc is not permitted to have more than one permanent unit. So basically, if you're certified as a facility, that has to be permanent structure. It can't move around, right? So a location is synonymous with the word address. So basically, if you're certified, you're issued a CCN number, then that is the permanent location with the permanent address. If you have several facilities operating out of your permanent units in different locations, each unit must enroll separately. Meaning, if you have one network and you have location A at this address and location B at that address, you need to have two certifications. Those facilities need to enroll and be certified by Medicare separately. And thus, they are subject to an audit by Medicare separately as one or the other, if that makes sense. Again, there's a couple of provisions for mobile units. Mobile units are not considered separate locations. They are attached to the main permanent Fqhc that operates them. And if Fqhc occupies several suites within the same building, that it's considered as one permanent unit. Let's say you have an Fqhc across floor 1, floor 2, and floor 5. Well, that's going to be considered as one facility that is certified by CMS. Hopefully that makes sense, that you're not confused yet. If you are, please submit your questions. So now let's dig into the requirements themselves. So we looked at HRSA, right? More of an expectation for you as an Fqhc to have certain things in place and the expectations that you have for reporting, etc. Now we are looking at the 491.12 emergency preparedness requirements for you as an Fqhc. Now, this is in place. The procedures are described in multiple documents. There are no exceptions to these requirements. Surveying started across all 17 provider supply types. And if, again, second bullet here shows that if you don't comply, right, if you don't meet these requirements, then the procedures of you getting kicked out of the CMS program is really described in the State Operations Manual Appendix G, even though it may be confusing because they mostly talk about rural health centers in that appendix. I highly recommend for you to read that appendix because the procedure of getting the auditors in, what the auditors would do, how they will find findings, how they'll find them, how much time you'd have to correct the findings, all of that is described in Appendix G. Very enlightening reading, and this is the worst case scenario if you were to be hit with the audit by CMS. Highly recommend for you to understand that. Now, for your emergency preparedness requirements, you must utilize a null hazards approach. This is the approach that CMS wants you to have. And pretty much in one word, it's you cannot just plan and put all the eggs in one basket. You have to be ready to respond to any emergency type because the concepts of emergency management are the same, no matter what kind of emergency you have. You still need to know who your partners are. You still need to be able to communicate well. You need to have evacuation procedures, no matter what kind of threat comes your way. There are some similarities. There are some maybe minor differences depending on the type of a scenario, but that is all considered in the all hazards approach. In red, you'll see the they released the rule and then they updated the Appendix G of the State Operating Manual. And that appendix, by the way, that came out in 2019 is where I get all the information you're about to see, which points out the surveyor's behavior, what they're going to be looking for if they came to you to the facility to audit you on the CMS emergency final rule requirements. Now, in red, there was an update to this Appendix Z, and CMS added the definition of all hazards must include emerging infectious disease threats. Examples of those threats include influenza, Ebola, Zika virus, and others. That was before Corona. But you may hear, well, as an Fqhc, you also must have an infectious disease plan in place. Well, yes and no. There's nothing that says that you must have an infectious disease plan separately in place if your emergency program is inclusive of considerations of how you're dealing with emerging infectious diseases. If it's a separate plan that addresses this, that's fine. If it's permeating throughout all of your policies and procedures, that's another way to do it. So keep that in mind when you're developing your progress. But basically, every single provider supply type must have a program in place, and the plan and program must be all hazards approach. Now let's jump into the requirements themselves. So CMS introduced these 4 core elements that you see on your screen, plus an additional 5th element that is optional. So all provider supply types must have A, B, C, and D, risk assessment, emergency planning, policies and procedures, communications plan, training and testing. You must have these in place, and they're very specific, and you have to have them. But then if you choose to use the integrated health system approach, it's an option for you. And I'll review that last because there are some considerations for you. Now let's jump into general requirements. We'll review them very quickly, because again, you have the slides, you'll have the point of reference here. But as an Fqhc, you must comply with this rule. You must comply with CMS rule, but also federal, state, local emergency preparedness requirements, right? So if your state supersedes the requirements of the feds, you must follow the state because they are more stringent. That's what it means. You need to establish and maintain an emergency preparedness program that meets all of the requirements of this section. Now, what exactly does that mean? So for risk assessment and emergency planning, you must have the program in place. Also, part of the program, you must have a plan. It's updated every 2 years. Every time you see red in the slides, that's the change that was brought on the omnibus final rule for burden reduction. Initially, CMS said you must have it every year, but the burden rule released it to every 2 years. So every time you see stuff in red, that's the most recent requirement. Some of that is stricken, but we are keeping some of the old provisions here, but this is the most recent. So every 2 years, you must review the plan. The plan must contain the following elements. It has to be based on a facility-based risk assessment and a community-based risk assessment, utilizing an all hazards approach. It must consider the strategies for addressing emergency events that you identified in your risk assessment process, right? So you can't just be talking about cybersecurity and ignoring a pandemic if pandemic is identified on your risk assessment. You must include and address strategies for patient population, the type of services you provide, and also continuity of operations, delegations of authority, and succession plans. That has to be included in your plan, emergency plan that is. And you must include a process for cooperation, collaboration with your local authorities, state, federal, regional, etc. As you see, you must have the process described, but you don't need anymore, no longer, need you provide the documentation that you try to contact these officials. This was the case in the original rule. This struck that down. So now you only need to include the process. As long as the process is described, that's fine. You don't need to provide any details. So for survey procedures, largely the procedures that you see on your screen are based on the interpretive guidelines. So the guidelines are in the Appendix Z. They said that they will update it. It hasn't been updated yet. But if a surveyor comes to you with an audit, this is what they're going to do. They're going to interview your leadership. They're going to interview staff. They want to see a written policy and the documentation of your program. They will want to see an emergency preparedness plan. They will ask your leaders, CEO maybe, or the CMO, how do you work with the hazards? What's the risk assessment process looking like? What kind of process do you use to include other facilities, etc.? They need to verify that your plan contains all of that and that it's being reviewed at least once in 2 years. And also they will see the risk assessments themselves, how you got there, the scores, the formulas. They will verify that the risk assessment is based on the local geographic location of your facilities, but also the community hazards. They will see if the plan includes delegations of the authority, succession plans, that you account for your population that you serve, etc. And also that you do have a process described for cooperation, collaboration. They will no longer ask for documentation that you try to reach out the officials. Okay, so that's the survey procedures, basically against what the rules are. Right, so second core element is policies and procedures. So for that, you must develop and implement preparedness policies and procedures that are based on the emergency plan that we just reviewed, and they have to be reviewed at least every 2 years. And you must have the following policy and procedures or areas that the policies and procedures must address are as follows. Safe evacuation from your Fqhc, including appropriate placement of exit signs, staff responsibilities and needs of the patients, a policy on sheltering in place for patients, staff, and volunteers, right? So what do you do under which scenario? A policy and procedure on system of medical documentation, preserving patient information, confidentiality, availability of records, etc. Policy on the use of volunteers in emergency. Notice that it's the policy on use of volunteers. Your policy could be that we do not use volunteers, but as long as it's written and it's available, that's what they want to see. So these are the policies that you must have in place. How will surveyors review this? Well, again, they will ask for written documents, copies of all policies. They will see evidence that you reviewed these policy sets at least once every 2 years. They will review the emergency plan versus the policy, how they match. They will look at the exit signs, how the evacuation takes place, how it will provide the shelter in place, how you deal with information, for availability of records, but also protecting confidentiality, etc. And also they will ask you to provide policy and procedure on the use of volunteers in emergencies and also any other staffing strategies. So that is second core element, policies and procedures. The third core element that you're required to have is the communication plan. So an Fqhc must have and maintain an emergency preparedness communication plan that is reviewed and updated again every 2 years. And the communication plan that's written must include all of the following: the names and contacts for your staff, entities providing services under arrangement, that's your contractors, patients, physicians, if they're not staff, locum tenens, for example, other Fqhcs within your vicinity, your sister programs who may be of support, volunteers that you utilize. You must have contact information for all federal, state, tribal, regional, local emergency preparedness staff that is of relevance, and other sources of assistance. Maybe you have a local hospital that you work with. All of this contact information must be documented. Notice primary and alternate means for communicating with your staff and all of the local, regional, tribal, state, federal emergency management agencies. What do you use for day-to-day communications? And if that fails, how will you communicate with all of these in an alternate way? Is it the radio? Is it the messenger? Are there different ways depending on the situation, etc.? But you must identify primary and alternate means. Another provision is that you must be able to provide information about your general condition and location of patients if the emergency is happening, right? So you need to provide for that. And means of providing information on what you may need in an emergency, but also your ability to provide assistance. So basically, how you're going to be able to ask for help and then say, well, we are not affected, we are able to offer help. So again, no surprise, the surveyors will come in and they will want to see the written communication plan that's filed for you. You need to provide evidence that's been reviewed at least once every 2 years, the contact information reviewed once every 2 years, that all of the required contacts are included in the communication plan, that you have alternate and primary means for communicating, and how you're maintaining the equipment. Let's say if you say radio in your alternate communication means, then they may ask to see the radio that you use and how you operate it, how you share information and medical documentation for patients if the patient is treated somewhere else, maybe HIPAA, etc. provisions. Also, how you're going to be able to communicate about your needs out and also ask for help and offer help as needed. So that was communications plan. Last core element, which is probably most troubling for FQHCs, is the training and testing. So as an FQHC, you must develop and maintain an emergency preparedness training and testing program that is based on all of the three elements that we just reviewed, right? You must base your training and testing on plan, the risk assessment, policies and procedures, and the communications plan. The program for training and testing must be reviewed and updated at least every 2 years. The training program must consist of initial training, then training every 2 years following that. You must document that the training took place. You must have files that demonstrate staff knowledge on emergency procedures, however you do that demonstration of knowledge. And if the policy procedures are significantly updated, then the training must catch up and it must be done more frequently. Let's say you had a major disaster, you updated your policies and procedures, then you need to conduct the training on the new sets of policies and procedures to staff, even though if it's out of the 2-year cycle. For testing, also known as exercising, so you must conduct exercises annually. As an FQHC, you must do the following. So this is where some of the changes came in place, as you see with a lot of red on your screen. So as an FQHC, you must participate in a full-scale exercise that is community-based every 2 years. When the full-scale exercise is not available to you or is not accessible, you can do a facility-based functional exercise instead of the full-scale every 2 years. If, and this is important because we're living through it, if you experience an actual natural or man-made disaster that requires an activation of your plan, then you're exempt from engaging in the next required full-scale or an individual facility-based exercise following the onset of the emergency event. So basically, you must have a full-scale or a facility-based functional every 2 years. If you experience an actual emergency and you document it and you activate your plan, you're exempt from that requirement to have it every 2 years. It would count as one of the exercises. So there's an additional exercise that you must do every 2 years opposite the year of the full scale or functional. And that may include, you can choose to do a second full scale or a second functional, or a mock disaster drill, or a tabletop exercise or a workshop that's led by a facilitator and includes a group discussion. Basically, before the omnibus, you had to do 2 exercises per year. Omnibus Rule 2019 came in. Now you need to do 1 exercise per year. That exercise must be full scale or functional or a real emergency. On the opposite year, the following year, you must do either one of the ones that we just mentioned, full scale, functional, or a real activation, or you could go for a tabletop or a workshop or a disaster drill. That's as simple as I can put it. And of course, you cannot just do the exercises. You must analyze your response and maintain documentation that you did all of that and that you revised the plan and there's an improvement plan and all of this, what we did well, what we didn't do so well, a kind of process. So that is the requirement for you as an FQHC for training and testing. I will point out that CMS released this memo on September 28th when COVID started bombarding everyone, and you can download it. Basically, it reiterates the fact that if you activate your emergency plan, you are exempt from the next required exercise. But please be careful with the timelines. You can't claim it forever. If you claim the exemption, that it would only suffice within that year for one type of the exercise. So there are some nuances there. Please read the memo. Survey procedures are very similar. You already, I think, figured it out. First of all, they will want to see if you do have everything written, that you reviewed the program at least once every 2 years, that your training took place once every 2 years, that you have verified the knowledge and it's documented somehow, that the files, they may ask for files and see what's in there, and that the files are updated every 2 years, that they may ask to see documents for annual exercises, of what kind of exercises you did, how you participated, how you analyzed and responded and updated your plans, etc. So again, you have the slides. I don't want to belabor this, but this was the end of the fourth core element. So the emergency plan, communications plan, policies and procedures, and training and testing are a must. You must do it. There's the fifth element that's called integrated health systems. And basically, if you have several separately certified facilities, but they are the same network. Let's say you're an Fqhc that consists of 5 locations. Each separately certified location may choose to participate in an integrated, coordinated program. They call it integrated health system. If you choose to go there, then each facility, each location, must demonstrate that they actively participate in the development of this integrated program, that the program was developed considering taking into account each location's unique circumstances, patient populations that you serve, services offered, and that each location is capable of actively using the program, of capable actively meeting each of the CMS requirements. If you do have an integrated emergency plan, you still need to have a community-based risk assessment that utilizes each facility considerations. You must have a documented individual facility-based risk assessment. So if your Fqhc consists of 4 or 5 locations, you need to have 4 or 5 individual HVAs, hazard vulnerability analyses. And then, of course, you have to have integrated set of policies and procedures. You need to have a coordinated communications plan and a coordinated training and testing program. Basically, if you are clumping 5 facilities together, you may have one set of communication rules, one set of training and testing rules, one set of policies that are applicable to all of the locations in your network. However, please make sure that there's documentation that each location in the network actively participated in the development, that they make sense. You are not sending a facility in a disaster-prone area for like a nuclear explosion because maybe they're located next to a power plant, sets of rules that are only applicable to another location that has nothing to do with the proximity to the power plant. That's the idea here. And for surveying, again, they want to see that it's being coordinated, that facilities actively participated, that your integrated sets of policies are applicable to each facility in isolation, but also as a unit, that the program's been reviewed every 2 years, that your leadership is able to describe how each one facility is included and how the program is updated. And I think this was it. This was a bit rushed, but we have some time for questions. So I think I will stop there and we can take any questions if we have any. I know it's a lot, so we have plenty of time. Brandy, Jonathan, anything?
Well, one question did come up and this was a question I received a couple days ago, and it was asking about, we received an emergency management plan template from Connect Consulting. The copy that the NVPCA currently has is from October 8th, 2019. And the question was in regards to its applicability to today, or if there's newer forms that we should be looking at. I don't know if that's something that would be easily answered.
I can easily answer this because I'm quite familiar with Connect Consulting. I think that entity has updated their templates, but the problem with templates is that each facility has to really work through the templates and apply the template to their facility and the network type. You can't just say, well, I'm just going to change the name in the template to my Fqhc and then it will be fine. You really need to apply all of that. And the way the templates or the packs of templates are structured together, it may or may not make sense. If you're struggling with the application of that to your Fqhc and your situation, there's other templates that are available. I will share with you guys, Brandy and Jonathan, the free templates that we have for communication plan, for emergency management plan that we released with PCAs. So that maybe fulfill some of the needs. But for the applicability of the content, I think you're fine. I think Connect Consulting did update it based on the omnibus final rule that updated the frequency requirements, etc.
Excellent. Thank you. The second question that I did receive was in regard to emergency preparedness guidelines with regard to cybersecurity. As everyone knows, our nation's been hit by a series of cybersecurity hacks and different things, which could be looked at as a emergency scenario. Is there any talk or anything in the plans for including cybersecurity in emergency preparedness?
Yes, the answer is yes. So if you look at the CMS emergency preparedness final rule requirements, you will not see necessarily explicit requirement for you to have cybersecurity plan in place. However, you will see a requirement to have an all hazards approach, right? An all hazards approach would include considerations for cyber because it's a relevant threat. Also, remember you're on the hook both from HRSA, the Apple approach, and CMS, which is a requirement, which is more of a stick approach for continuing your business, right? Continuation of operations was mentioned in both. And how can you continue operations if you're affected by cyber and you cannot function? So you have to plan for that. The problem is that it's not very, what's the word? It's not in its separate lane, right? Cyber may be affecting your emergency plan. It may be affecting your business continuity plan. It may be affecting your data management or data recovery plan. So you need to be able, and that's the challenge, you need to be able to have policies and procedures in place that would address cyber that go across the whole organization and not just get stuck, for example, for IT procedures, because that may or may not suffice. Well, if the IT folks know how to isolate the computer from the network, what does that mean for a frontline nurse who may not know or be trained on how it relates to her to go offline for paper procedures, or for frontline person who is then affected into the communications to make sure that the patients who are coming for appointments are contacted if you don't have the HR access. So all of this is very complicated. But yes, cyber is permeating the whole rule and the requirements, absolutely. And I would say that you must consider that and have a hazard-specific cybersecurity attack plan on file that is a complement to your all hazards approach documents, if that makes sense.
Yeah, perfect. I appreciate your explanation. So I don't believe there are any more questions, but I just want to say thank you to everyone for attending today's webinar. If you have any further questions, please contact me at jmcdowell@nvpca.org. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate if you complete that survey and provide feedback. Thank you for joining us today, and have a great rest of your day on behalf of Nevada Primary Care Association. And thank you, Alexander. We appreciate you being the body of knowledge for this presentation.
Absolutely. You guys know my contact info. Either connect with me through the PCA or directly. I'd be happy to answer additional questions. Have a wonderful day, everyone.
Thank you.